Hello, everyone. Welcome back to the podcast. My name's Chuck Dowell. I will be the host of today's podcast. Today, we're going to do another case description. I've seen a couple of these come into the clinic recently, so I thought this would be an interesting case to review or go over. Again, this will be a case review, so the x-rays and imaging that I kind of discussed during the podcast will be on our YouTube channel. So if you want to go over to the YouTube channel, you can see all the images, the MRIs, some images kind of discussing the anatomy itself as well. So for this gentleman, this is a 16-year-old who came in and saw me at the orthopedic urgent care. He says he was wrestling a week earlier in Utah. His foot got caught on the mat kind of under the other wrestler or the opponent. And he had kind of this forced external rotation of his ankle. And he showed me this with some pictures and videos. Again, I think a lot of patients do come in with videos, and the videos can be quite helpful to help to distinguish the mechanism of injury, where for me, if I can get a good establishment of the mechanism of injury, oftentimes I can think about the kinesthetics of the joint, what stresses that joint went through, and potentially what that would show me would be injured. Anytime somebody comes in and they describe not this traditional ankle sprain, so you can see the image on the, again, YouTube channel right now. So when we talk about the ankle itself, most traditional ankle sprains, there's an inversion of the ankle. So the ankle rolls inside. And typically this injures the ligaments on the outside part of the ankle. So the anterior tibiofibular ligament, it's typically the tightest and usually the one that gets injured first, especially if it's a little bit of a plantar flexion and an inversion type activity. And then typically the calcaneofibular ligament will get injured second. Now sometimes this can be injured in isolation with just a straight inversion injury with no plantar flexion as well. And then usually if those two are injured or torn, it can then possibly injure the posterior tibiofibular ligament. But typically the ATFL and the CFL ligaments are the ones that get injured the most and are first. And so usually when you're doing a physical exam, they'll have some tenderness here in this anterior ankle area. When we're looking at and talking about the ankle anatomy itself, you can see again on the depiction here, the anatomy of all the ligaments and kind of tendinous attachments throughout the ankle. Again, most commonly injured is this anterior tibiofibular ligament, which connects from that anterior distal aspect of the fibula to the anterior lateral aspect of the talus. Calcaneofibular ligament is then usually secondarily injured as well. And then the posterior tibiofibular ligament can be injured. But again, sometimes patients can have injuries to this anterior tibiofibular ligament, which sits a little bit higher and connects that anterior aspect of the fibula to that distal tibia. And posterior to that is a posterior tibiofibular ligament as well. We often refer to this as the syndesmosis, but this is actually the ligamentous complex connecting those distal and or that distal joint. The syndesmosis extends a little bit higher to this itself. So when some people refer to the syndesmosis itself, they will refer to the entire complex of the posterior or anterior tibiofibular ligament and this interosseous membrane, especially this distal aspect of the interosseous membrane that connects the tibia and the fibula all the way up through the ankle. Oftentimes there'll be kind of the syndesmosis is all accompanying with all of this. Sometimes just this inferior aspect of the interosseous membrane can be referred to as a syndesmosis as well. But again, when we talk about high ankle sprains, syndesmotic injuries is typically what we're directly referring to and discussing. So this gentleman, again, 16-year-old, came in. He was ambulating on it. He had tried to treat it conservatively for approximately a week with, the typical elevation ice, anti-inflammatory meds. He had not wrestled or tried to wrestle one time since then, but unfortunately was not able to wrestle due to the pain within the ankle. He came in, we got x-rays, including 5 views of the foot and ankle, our typical x-rays that we get. You could see his x-rays here on the screen. So x-rays in themselves did not show any significant changes to the ankle itself. No obvious fractures that were seen when looking through the x-rays themselves. On his physical exam, though, this is where, I think most of the important information was gained. He had quite a bit of tenderness, but his tenderness was not in this traditional tenderness we see distal where that anterior tibiofibular ligament tenderness was at. His was up here in that anterior tibiofibular ligament area. So again, when we're discussing and look at the anatomy, his tenderness was up in this area where that junction of that distal tibia and fibula was at. He did have some mild tenderness around these lateral ligamentous structures, but majority of his pain was up into this area. He also had increasing pain with dorsiflexion of his ankle, as well as dorsiflexion and external rotation, which oftentimes can stress this joint itself. So again, the mechanism of injury for these high ankle sprains is usually this foot rotates outward, so this forced external rotation with internal rotation of the tibia. And so usually this is with the ankle in a little bit of a dorsiflexed position. They can have eversion of the ankle as well, which is the opposite of inversion, and that would push that talus against the distal fibula and affect more of this anterior tibiofibular ligament or syndesmotic area. So anybody that comes in and has a mechanism consistent with this, I always worry about these high ankle sprains and tend to spend more time with my palpation and evaluation regarding this. The patient also did have some tenderness over his deltoid ligament, which I think and or typically often corresponds to a high ankle sprain type injury as well, anytime this deltoid ligament is injured. And that may have meant he had more of an eversion type injury than just direct a external rotation type injury. When we talk about what to look for on the x-rays regarding these patients, there are published x-ray guidelines when evaluating the ankle, especially looking for deltoid ligament or high ankle sprains. You can see on the picture now, typically when we're doing ankle imaging, we're getting an AP view and a mortise view. These two directional changes do adjust the overlap of the distal tibia onto the fibula itself. So normally during this AP view, the recommendations would be at least more than 10 millimeters of overlap, or normally more than 6 to 10 millimeters. I typically was taught about 50% of overlap usually shows that there's no concern for distal tibiofibular ligament injury. And then on the mortise view, there should be at least 1 millimeter of overlap. So if we look again, kind of looking at the spaces we're looking at. So the medial clear space, as we call it, would be this space on the inside part where that talus and that distal tibia meet. That'd be evaluating if there's a possible injury to the deltoid ligament itself. We want that medial clear space, again, to be less than 4 millimeters. This is a mortise view, so we want that distal tibial overlap on the fibula to be at least 1 millimeter or more. And again, we don't want to see significant tilting on the talus here itself as well. And then when we're looking at the AP views, you could see here we want usually at least more than 10 millimeters. Some documentation shows 6 to 10 millimeters of overlap at this distal tibular fibular space. And then again, at least less than 4 millimeters of clearance within this medial clear space. And then the distal, space where that tibiofibular junction is at, as the clear space, we call it there, should be less than 5 millimeters as well. So these are quick things that you can look at from an x-ray perspective to see if your x-rays meet any of these criterias. If it's a little bit ambiguous whether the x-rays show these changes or not, we can often do gravity stress views. It's questionable whether these add diagnostic value, as they're often dependent upon how the stress view is done. So when we're talking about these gravity stress views, we have the patient lie on their side. We put a little pad underneath their mid calf area there, and we have gravity naturally pull the leg down and shooting that x-ray, looking at that. And when we look at the x-ray itself, this is what it looks like. And the thought process is if there's an injury to the deltoid ligament, if there's a distal fibular fracture as there is with this x-ray, or there's an injury to the distal tibiofibular ligament, the ankle will naturally fall to gravity and it'll open up that medial clear space, and we'll see more than 4 millimeters of movement in that medial clear space. And so some of the providers I work with do these gravity stress views regularly, some do not. One thing I was taught, you can mimic this specific movement while evaluating a patient and to see if there is an injury to this distal tibiofibular ligament or syndesmotic area. So oftentimes when I'm evaluating these patients, I will put them up into dorsiflexion and I will do some forced external rotation to kind of recreate the injury itself and see if this causes pain within the patient. And oftentimes this will cause increased pain in that distal tibiofibular junction, which is consistent with concerns for syndesmotic injury. And you can decide if you need these gravity stress views or possible an MRI at that time. When we look at the movement or the anatomy of the ankle joint itself, oftentimes you can see this movement with their plantar flexion, dorsiflexion activities. There is some natural slight inversion to the ankle itself. When we talk about anatomy, during dorsiflexion, the wider anterior talus engages the ankle mortise. Oftentimes, the distal fibula externally rotates and translates proximally. During plantar flexion, the narrow posterior talus engages the ankle mortise. And during natural gait activities, the ankle mortise can fluctuate or widen approximately 1 millimeter. So that's why with this wider anterior talus and this forced and or dorsiflexed activity, this is why we see these injuries themselves. So again, when we look at dorsiflexion itself, you can see that when we dorsiflex, there's some slight external rotation, slight abduction of the ankle, causing that fluctuation in space between that distal tibiofibular junction, which leads to the most common mechanism for this injury in that forced dorsiflexion. So again, when we recreate this position and that full dorsiflex position, we're pushing that wider anterior aspect of the talus into the mortise itself and externally rotate, we can see if there's an injury to this distal tibiofibular ligament. So on this gentleman, we did get a gravity stress view. I don't think and would not say there's significant widening within this medial, approximately 4 to 5 millimeters, I think, when we measured it. We did end up getting an MRI to evaluate to see if there's a concern about injury to this anterior or posterior distal tibiofibular ligament. And so when we're looking at the axial images of the MRI, here's our talus coming into the middle, our fibula out here, our distal tibia in here, and here's the posterior tibiofibular ligament here. And then as we scroll through, there's our anterior tibiofibular ligament. And you can see there's an injury to that complex. There's a complete tear within the anterior tibiofibular ligament itself. Now, a couple other parts of anatomy to look at. When we're looking at the MRI from the axial views, you can see this here, and this is typically the transverse tibiofibular ligament. It sits superficial to the deeper posterior tibiofibular ligament, which is a bit more of a fan-like fashion, which you can see kind of on this view here. So the superficial transverse tibiofibular ligament here, this deeper fan-like posterior tibiofibular ligament, and then coming in there itself. And then looking at the anterior aspect, this would be the anterior tibiofibular ligament we're looking at here. And you could see there's a complete disruption of that. You can see the tear and also kind of the radio-opaque fluid collection in the area. When we're looking down, this is a great view here of the anterior tibiofibular ligament, or talofibular ligament, I apologize. So the ATFL, you can see coming into the view right there. And so again, when we look at our coronal images, kind of scrolling through, again, getting our bearings right here of anatomy. So this is our talus here, tibia here, fibula comes into the picture here. You can see kind of our deltoid ligament kind of connecting out on that medial aspect. We can see some fluid collections kind of right in that distal tibiofibular junction. You can kind of see fluid collecting all the way through there. And so typically that denotes that there's an injury directly to this tibiofibular ligament itself. Sagittal views don't show us much. If we think there's an isolated posterior malleus fracture, we could see some injury to that itself. We could see some fluid collection within that distal tibiofibular ligament junction. We could see our perineal tendons coming down, here. So we could see if there's any concomitant injuries to those perineal tendons as well. These do have associated concomitant injuries that can happen with the injury itself. If you look at the literature, 15 to 25% of the time you can get an osteochondral defect. Up to 25% of the time you can get an injury to these perineal tendons as well that you can see on the MRI image here. And then ankle fractures, Weber type C, Weber B ankle fractures, and even fractures to the base of this fifth metatarsal can be associated as well. And then some will have an injury to the anterior process of the calcaneus. On this gentleman, we didn't really see it, but oftentimes I'll see a bruising injury to the dome of the talus as well, and that's usually where that chondral injury happens. So for this gentleman, because he was a high-level wrestler, he really wanted to get back to wrestling activities. We did recommend doing a repair, and so for him, we did a tightrope type fixation across that distal tibular-fibular junction to try to repair that. He also had an arthroscopy as well, and during the arthroscopy, just looking to see if there's any concerns or injuries to the articular surfaces, which you can see here, there's no direct injuries to those. Sorry, trying to get my... There you go. No direct injuries to those talar surfaces themselves. The dome of the talus and distal tibia all looked okay. So no evidence of chondral defects or chondral damage. Was able to do the tightrope type fixation and then follow the normal postoperative protocol for that. Usually the protocol for that would be non-weight bearing for 6 to possibly 12 weeks postoperatively, especially if there's a screw fixation. With tightrope fixation, usually there's not a concern about breaking. So usually about 6 to 8 weeks will allow for progressive weight bearing, and then increases weight bearing every 2 weeks after that. Start range of motion and physical therapy activities. If we're treating this conservatively, non-surgically, typically we're going to put these in a cam walking boot, usually and have them non-weight bearing for 3 to 4 weeks. If it's just a sprain without the diastasis or ankle instability, typically we can get away with these non-operative alternatives. Usually delayed weight bearing can allow for quicker recovery and usually prevent the prolonged and high variability of recovery that is often seen with these high ankle sprains. If you've ever seen these patients come into clinic, they can and or seen evaluations and or athletes, they can take quite a long time. I mean, anytime I see a football presentation and they say high ankle sprain, that football player's out basically the rest of the year. It takes them 3 to 4 months to recover. So we tend to try to treat these a little bit aggressively off the top. Some doctors will do cast immobilization for 2 to 3 weeks. Some will do boot, wear the boot basically at all times for 2 to 3 weeks, limited and or no weight bearing. And then as they progress after that with followed up x-ray images, they can do some progressive weight bearing activities. I hope you enjoyed this presentation. Again, this was an interesting case. I feel like 3 or 4 of these come in are at a relatively the same time. 2 were wrestlers and 1 was landing a long jump, and he was in that forced dorsiflex position, but because he landed in the sand, he had a forced eversion. And again, when I hear those things in my head, I think concerns for high ankle sprains because I know the kinesthetics of the ankle, as we showed you. And, when we're in that dorsiflex position, that wider anterior aspect of the talus often puts more stress on that syndesmosis itself. Again, I hope you enjoyed this. Hopefully we'll have some more case presentations. If you like this, please give us feedback. I like the interactive nature of these presentations to allow you to see the images, that I'm looking at as well. Have a great day. Thank you.